This week on the BackTable Podcast.
Never forget that it's a sacred opportunity and privilege to take care of people. They're bearing their soul. They're telling stuff to you they don't tell anybody else, including their closest partner. Well, that's a privilege. So enjoy every moment. I guarantee you they'll teach you more about yourself than you'll do for them if you really open up and listen to them. Listen to their stories, because you're storytelling. Basically, you're listening to their story, and if you put empathy in there, your ability to be their doctor, to make them compliant, what's in their best interest, is so much easier than trying to talk them into something. If they trust you, they'll just do it because they feel like you're really interested in them.
Hello, everyone, and welcome back to the BackTable Podcast, your source for all things urology. You can find all previous episodes of our podcast on Apple Podcasts, Spotify, and at BackTable.com. Hello, everyone. This is Raj Satkunasivam. I'm a urologist and associate professor at Houston Methodist Hospital. It's a real pleasure today to guest host this episode with my colleague, Rose Khavari, from Houston Methodist. Rose, headed over to you to introduce yourself and to introduce the topic of our conversation and our guest with us today.
Thank you so much, Raj. Well, I'm super excited to be here with my mentor, who I have gotten to know for decades now. I'm Rose Khavari. I'm a Ben and Wendy Moreland Professor of Urology at Houston Methodist Hospital. And today we have Dr. Timothy Boone, and we're going to be discussing empathy, social awareness, and leadership in medicine. So Dr. Boone, you're truly a legend in urology. I really tried to summarize my introduction to a few paragraphs, and it was tough. But here we are. Dr. Timothy Boone is the Director of Education for Houston Methodist Hospital, Houston Methodist Academic Institute. He's a Professor of Urology at Houston Methodist and Weill Cornell Medical College. He also holds a professorship at Texas A&M, and also clinical professor of urology for Baylor College of Medicine. In 2014, Dr. Boone was appointed as Associate Dean for Texas A&M University College of Medicine at the Houston campus, which we're going to talk a little bit more about that. Dr. Boone earned his Master of Science in Physiology and his PhD in Neuroscience at the University of Texas Graduate School of Biomedical Sciences at Houston. And then he completed his MD and PhD program at the University of Texas Medical School in Houston. And then he went on to do a urology residency at the University of Texas Southwestern Medical School in Dallas, where then he joined the faculty in 1991 for a couple of years. After that, he moved to Baylor College of Medicine, and he joined the Scott Department of Urology. In 2000, Dr. Boone was named Professor and Chair of Scott Department of Urology, where he served until 2008 as a chair. It's actually during that time that I had the privilege of meeting Dr. Boone as a urology residence applicant, and then later on as a junior resident, which for me, it opened up a whole door of opportunities and exposure to a field that I cherish, which is the neurogenic bladder and pelvic reconstruction. So in 2009, he actually came over to Houston Methodist Hospital and established the Department of Urology here at Houston Methodist Hospital. Dr. Boone specializes in the treatment of patients with urinary incontinence, complex voiding disorders, bladder problems related to neurogenic bladder. And for decades, he actually maintained an active research lab where he did basic science, translational, and clinical research specific to neurogenic bladder. Throughout his career, Dr. Boone has written over 200 publications, has trained and mentored many, many individuals, including myself and many of our faculty here in our department. He's a member of the American Association of Genitourinary Surgeons, Clinical Society of GU Surgeons, and was elected as a trustee of the American Board of Urology in 2006, and then served as the president of the American Board of Urology from 2011 to 2012. So this is truly a very snapshot and just a summary of Dr. Boone's CV. But I'm going to call you by Tim and Raj. We are so honored to be sitting down with you today to discuss your journey in urology, your perspectives on empathy, social awareness, and leadership in medicine. Thank you for being with us today.
Tim, I echo many of the same sentiments Rose shares. You've been such an instrumental mentor for many of us, and one of the main reasons that I came to Houston Methodist and have had the privilege of knowing you for about 7 years now. I wanted to just kind of start off where it all started for you and what on a personal level brought you to urology. And before, you got to be Tim Boone that we know, how did you first become interested in urology?
Well, first, thank you, Raj, and thank you, Rose. It's a privilege to be here and speak, and it's truly been my honor to recruit both of you and be standing by as a mentor and help in any way. And I'll talk a little bit more about leadership and why that's so important. I was very fortunate. My father was a urologist in Dallas. My father loved his job. He never complained at all. He embraced new technology. Even when he was near 80, the robot was fascinating to my dad, and he loved to go in the operating room and watch it. He started his own private practice in Dallas, had a fairly large group when he retired at 82. But back in the day as a college student, I came home in the summer and we actually scrubbed in the OR and handed instruments in the operating room. There's no way you could do that now. So as a college student, I actually watched and helped my dad in the operating room. How cool is that? And I trained at UT Southwestern in Parkland, where I came to know Harry Spence, and Harry had trained my dad. He's a giant in academic urology, and Harry lived long enough to see me hired by Paul Peters to join the faculty, which really, for me, closed a loop that was very meaningful to me. So, like many urologists, there are a lot of father-son urologists. If you look around, I would happen to be one of those. So, along with being privileged that a father is a urologist, it really led my pathway to start.
Tim, we're going to get back to what you just mentioned about getting the young minds excited about medicine and surgery because you're so involved with that. But both for me and Raj, we've seen your commitment to really elevating the education, research, administration, leadership. How did you realize you actually had this passion for improving or elevating these areas?
Well, on the education front, as a resident, I realized I really love teaching. I love my junior residents rotating on the team with me. And right then I decided that I wanted that as part of my career. Although my father's partners were really almost desperate to get me to join after training their group, honestly, personally, I felt it sort of boring. I love to educate. I love research. And to go right into practice, it just didn't fit my career needs. So I think the biggest thing is I had tremendous educators as teachers and mentors, and I could never thank them enough for what I had. UT Southwestern was absolutely fantastic, but the opportunity to join Baylor College of Medicine in 1992 was really an opportunity that I could not turn down. Peter Scardino hired me, put me in a position to do my thing, and pretty much left me alone. And along with the original chairs, who were still very active at the time. In fact, Russell Scott was hired by Mike DeBakey to actually start urology for Baylor College of Medicine. I had the great fortune of knowing Russell quite well. He endowed the department at Baylor, and Russell was actually the original director of the AUA Office of Education, which was housed in Houston. And so that was a tremendous influence. Their dedication to education was around me since I started. But Gene Carlton was instrumental. Gene was the next chair, and Gene really showed me how to grow faculty by watching Gene. He put people in places to succeed. He got out of the way, and he loved being a mentor when you needed him. He was a man of few words, but what he had to say was very meaningful. So I have Gene to thank for believing in me 100%. So that's the education side. The administrative side, really, I was blessed with a grandfather, and my grandfather was the Dallas Methodist hospital administrator for 30 years. Every Sunday after church, we went to the hospital, to the dining room, believe it or not, hospital food, but we ate lunch together. And then after lunch, he would take me through the hospital to let me meet people. He would talk about what they did and socialize with the employees up and down the line. It could be a physician, it could be housekeeping, it could be anybody. He pretty much knew them all. And unlike our administrators today, Poppy was out and about. He didn't sit in the C-suite. He knew everyone by their first name. So he was special to me, and I actually named my first son after my granddad. So both education and administration are really in my blood from a very early age. But I have my mentors to thank. They were all perfect examples of what it means. And I just wanted to pay it forward in my career. So that's really where I am at this point in my career. As I wind up my career, I purposely decided that this is how I wanted to finish up.
Tim, just on that topic, the inspiration for this podcast, a big part of it came from our discussions surrounding a critical lecture that you give to medical students now, particularly as they are finishing up their didactics and are about to start seeing patients for the first time and heading into clerkship. And, it really centers on the art of medicine and doctoring, if you will. And in it, you reflect a lot on your particular take and experience and view of empathy and social awareness and leadership. Could you share with us why, this particular role that you have now in really guiding these medical students as they springboard into their clerkship is, first of all, important, why these topics were particularly important for you to, have a role in the medical school and in these young minds?
Sure. It's a great question. I start by a question. I say, when a patient comes to see you for a medical problem, do both of you establish a doctor-patient relationship based on the number of papers or grants you've written, or some position you hold in a chosen subspecialty society? I hope not. Just like art. Doctoring is a learning process that you never finish. It's a journey based on a calling to medicine. It's not a job. It's a privilege. What people share with you is truly a privilege. But we've lost so many of the soft skills to be an effective doctor, and they're still slipping away, unfortunately. I see physicians actually stand in the doorway and talk to their patients in a rush just to catch up with their schedule. I see them turn their backs to patients and begin typing away. I see their inability to read a patient's body language or that of a spouse or a family member. Those are big mistakes. So I'm determined to see what I can do to educate brand new doctors to the soft skills that will really make them or break them as real doctors. And I think it's important to emphasize the critical parts. Sit down, make eye contact, touch the patient, shake their hand, or a gentle touch of the knee are all really important. More importantly, shut your mouth and listen. I may be old school, but I firmly believe this. If you do it, they'll, in all likelihood, give you the diagnosis by listening. You don't have to order a zillion tests. You just have to listen to the patient and take a good history. Those are really important. And if you do these well, I may be old school, you don't have to advertise at all. The word will get out. They'll tell their family about your level of care, their neighbors, and everybody who needs care. The nurses in the OR on the floor will always recommend you as the person to go see. You don't have to ever advertise. Your schedule will be jam-packed. You'll be full. And it's really important. I think most importantly is listening to the patient's story. But with all the facts, it's also very important to understand their fears, their hopes, and all the implications associated with the objective information. In many ways, that's just as important or more important. It certainly impacts compliance of the patient. And this is where self-awareness and self-management come to play. They're vital to your diagnosis and management, along with a careful exam. You got to be cognitively aware and emotionally aware of what's going on. This is your narrative competence. Are you narratively competent? And empathy is really these shared feelings versus sympathy. So empathy is feelings. Being sympathetic, you're being a spectator. They're very different. So don't confuse the two terms. They mean something differently. Meaning and empathy is apprehended collaboratively, like a reader and a writer. You need both sides in order to have a conversation. And You need an observer and observed, the patient and the physician. That's what it's all about. And only then can you really hear what the patient's saying. If you ignore the other, you don't hear anything. And self-awareness then is real mindfulness. That's a buzzword, but it really means you're self-aware. You know who you are at the moment. You know what you're thinking, and you know what you're feeling. You recognize your strengths and your weaknesses. And I learned to pause at the door before entering a patient's room and basically check in with myself. Where am I right now? Am I distracted? Am I upset about something else? Just recognize those so I can put them aside when I go in and talk to the patient. That check-in is really important. It's much like scrubbing the operating room. People have idle chatter going on when you scrub. It's much like golf. Walk through the steps of the operation. Where's the golf ball going to land? What club do you need? Just quickly rehearse in your own mind what's going to happen in the operating room. That's a great skill to have while you're just standing there scrubbing instead of idle chatter. Use that to kind of pre-gain what you're fixing to do. I think it's a very effective way to be there. And I try to teach people with me to do that. Just sort of think your way through it. It's the same way with the pause at the front door. What am I carrying in the room with me? And that's very important. Also, self-management is your ability to set your ego aside, know and consider your team. You're more a leader of a team, whether you like it or not, but you got to park your ego at the door and really learn to use emotional control. Don't get rid of emotion, but know how to control it. This demands you be a leader, not only of yourself, but with those around you. And the only effective leadership model, there are many of them, but it's all about servant leadership. You're there to serve others. You're not there to serve yourself, your own ego. We see many departments of urology that are built around someone's ego. I submit that they're not a leader. They're certainly not a servant leader. When I decided to be chair at a fairly young age, I had to recognize that I needed to set my career, my personal goals aside, and I needed to be a servant to the faculty and the staff who were going to build this department and carry it on. And it's really how you serve your team. Around leadership, I was asked to share my path to leadership during a Lunch and Learn program several years ago. The hospital sponsored it, invited the hospital to come, and I decided to really title my talk Life Stones. And that's just serendipitously, I'd watched a movie of a little kid skipping rocks on the water, on the calm water. In many ways, skipping across a calm water, the rock hits the water and then rises again and keeps moving. So these contact points are life events that we all have. They sort of shape how you feel, certainly emotionally, and how you interpret information around you. So being self-aware of these and letting them into your mind space are important to tap your empathy. That's where it comes from, these life experiences that you have. So it's important to let the emotions elicit that in you, but manage them. So that's an art, being able to feel what the patient's feeling, but manage it so you're not talking about yourself, but you're talking about what the patient's experiencing. That's where the art comes in. When you see patients struggling with a diagnosis and all that's about to come, you'll feel similar emotions that well up in you. This is where your capacity to empathize can be most effective as long as you manage it. It's very important.
There were so many practical examples and tips for us to follow. And I've actually personally have seen many of these that you mentioned in action. The fact to visualize the surgery, go through the steps before the case. I emphasize that to the residents all the time now, is that let's visualize it. This way we can prepare better for the case. Also, I think for me and you, we see a lot of patients who, they see us long-term for their neurogenic bladder. Their life has changed in a split second. They've had a spinal cord injury and cervical level, and that's it. Their life is totally changed. They have end-stage IC, advanced MS, and there's really not much. The care we offer them usually can go beyond the surgical urological therapies that we're used to. And then that's when that empathy, that you talk to us about comes in, because that's when we can actually sit down and really hear the patients and try to be empathetic with them and help them in their journey of their care that they need. Is there anything else that you want to add specifically about empathy? Anything else that you think we need to be more aware, to remind ourselves again over and over, to try to hear the patients out?
I think so. I think as you approach a diagnosis, you got to let the empathy in yourself come up. That's the connection you see, and patients feel that. I guarantee you, if you pause and they see you're impacted by their story and you want to share the story, that has a bonding effect. And suddenly you have the relationship. Without it, it's touch and go. You never quite know. But you'll feel things come up. When I did oncology early, that's one reason that I couldn't do oncology. It was just too emotional for me to do. So I had to find something that I really enjoyed. But it wasn't oncology. That was just too hard for me. But I felt those emotions rise up. And I'd had death. My little sister died of metastatic breast cancer at a young age and left children. I'd been through my own experiences, and I just realized that I'm not sure I can keep my emotion in check and be as effective as I wanted to be. And that's really why I pursued neurogenic bladder. Again, it was a longer period of time. I didn't have patients who were facing death all the time. It was really managing Rose. So I think that has a lot to do with my decision-making, but empathy's always there. The tragedy of some diagnosis is just lifelong when you give them that. And you'll feel it well up. That's the connection, but then you just have to let it connect to the patient and then focus on the patient. But you'll feel that it's physiologic. That's what's really interesting. When they did a study of primates where they watched mirror neurons, same brain area in general as humans, and when the animals were presented with a traumatic experience and they saw it in another animal, they triggered the neurons. You could see them fire up electrophysiologically. So you have mirror neurons when you're hearing a story. You put them in context by these neurons starting to fire. And that's what's happening to you when you hear patients' stories or you feel empathy. That's exactly what's happening. It's important to tap it, but not let it overwhelm you.
I think as I'm getting older and practicing medicine more, truly practicing it, I think earlier on, it was really hard for me when I heard those difficult situations, difficult diagnoses, and I heard patients, discomforts. It was hard for me to acknowledge that and really deal with it head on. It was easier to try to block or dissociate to be able to move on. But as I'm getting older and now I actually take my time when difficult conversations or difficult emotions from the patient comes on, I can actually sit down and pause and acknowledge that sad, if they're crying, acknowledge the cry, acknowledge their sad emotions and give it a little bit of time so they can process it, I can process it, and then we can kind of move forward. But I think that's part of the empathy that we all learn throughout our career. And as you mentioned, just to acknowledge it, but not let it overwhelm us.
I think it's key to the doctor-patient relationship. If that's what's important to you in medicine, and I can tell you, having retired from clinical practice, I don't miss the whatever number sphincter I'm doing. I miss teaching with a fellow especially. I don't miss that. I miss my patients. I miss the experiences like that. I miss what they taught me throughout my career. That's all that lingers. The rest of it, honestly, it doesn't really linger. You think it would, but it doesn't.
Tim, there's so much to unpack here. I especially was thinking about how you've challenged your particular life experiences to draw towards building really meaningful therapeutic relationship where patients really look at you as truly authentic. And I think that's, really the joy in medicine that you're referring to. One of the things that caught me as you started to introduce your motivation to speak to these medical students is really some of the threats that you see to empathy, some of the challenges that we all face, both, in practice, but obviously our learners face at various stages. Can you speak a little bit more about, what you see as, sort of the threats and is there a bit of a reduction in empathy, or what do you see as the problem?
Well, it was sort of new to me when I began to see the need of doctoring and began to read. And I ran across a lot of studies that track medical students. And it was really interesting to see several of the studies where they graphed, they did it very scientifically, but they took a cohort of patients students who were trained and those who were not trained. And what was interesting is it didn't really matter when they started their clinical rotations, they fell off a cliff in terms of empathetic indices. They used a multitude of tests, but they noticed that every time you took a medical student and moved into a clinical environment, their ability to empathize stopped, became markedly declined. And then they began to really inspect why that was. And it was a coping mechanism. They felt this flood of emotion. They all did. Everybody experiences loss and grief, but they didn't know what to do with it. And so they shut down. They began to shut down. It was too hard to deal with this emotion. It came out of nowhere. It was easier to become callous, turn it off, bury it, not talk about it. And what they saw is the same thing was happening around them on a resident team. And so they lost that ability to empathize, largely because they didn't understand it and didn't begin to self-manage what was going on. Their awareness was limited. And so I think that's what drew my attention mainly to the need for this, to explain what you're probably feeling. It's okay to feel, but can you manage it? And can you pull it into the doctor-patient relationship so it becomes a positive way that you could communicate? So that's largely what was happening and why it drew my interest.
Tim, we're going to shift gears a little bit and talk about leadership now.
Sure.
You've been a chair, you've been a leader at two different institutions that, although both of them are at Texas Medical Center, but they're very structurally different institutions, Baylor College of Medicine and Houston Methodist Hospital. You've mentioned this before, that being a leader is really not a choice as a physician. Can you share with our audience, what do you mean by that?
Well, if you think about the examples I've given, the ability to lead the people behind you in terms of education, that's a form of leadership, certainly servant leadership. I think you're always followed and tracked when you're making rounds and you're the attending. You're a leader. If you're in a group, you're dealing in the OR, you're dealing in the clinic, people look to you to be the lead, to tell people, keep them up to date, communicate, but basically tell them the direction you're going in. So it's not a choice. If you're going to be a physician, you're going to be a leader at some level, or you're going to fail. You just won't be seen as somebody who has the confidence to be doing what you're doing. You could take leadership to whole different levels, but at a minimum, even in private practice, you're going to be a leader, and you just need to get the skill set together to make you an effective leader. And sometimes that's experience. Sometimes it's a mentor who teaches you to be a better leader. When people come to you and they need mentoring, sometimes it's you need to step up and lead. You're following, and that's why you're frustrated. So you need to get out front and lead and do the work that's required to be a leader. And it's very gratifying, but spooky. So some people are just scared by the idea. You just sort of have to get over it and accept that you have to be a leader.
I think it's so important to acknowledge that you actually introduce that concept to the medical students early on, and you tell them, this is going to be thrust on you whether you like it or not. We hear a lot of lists about, what the qualities are about, transformational leaders and what XYZ needs to happen. I think that you hone in on a couple of things regarding, self-awareness and self-management as perhaps the most important parts of being a good leader. Could you share some tips with us for self-reflection? I know you've talked to us about journaling and how that was useful for you in your career. Could you tell us a little bit more about that?
I think it's critically important. People that don't self-reflect keep stumbling on the same problems because they're not self-aware and they don't think about it. So I tell the students, what's your sanctuary? Where do you go to self-reflect? Now, you need to every day. It may be a couple of minutes. It may be a whole hour. Now, you could call it meditation, prayer, whatever you want, but you need to sort of check in with yourself and reflect how things are going. And you need to find that special place. It could be anywhere. It could be a park bench. It could be a walk with your dog. It could be a variety of things, but you need to be self-aware and connect with yourself every day on a regular basis. You'll find it very gratifying. It'll allow you to grow as a human by simply doing that. And often you're tired and you need self-reflection. You need to carve out time to rest. Because when you do, you'll have this flurry of ideas and things that come to mind where you're not so repressed by the day in, day out work. You'll be most creative when you allow yourself to self-reflect and get some rest. Let your mind rest. That's really important. I have a cousin that I'm the oldest child. I had a cousin that was almost like a big brother to me. Dan's 6 years older than me, but he was very important to me, and he journaled throughout his career. He's written an autobiography because of journaling. He writes beautifully. He has Parkinson's now, and he's probably in the later stages, but Dan still writes about what it is to have Parkinson's, how it impacts him, how he's angry, and that all comes out of his journal. But he sort of transposes his journaling into written word, and I found that very effective example as a mentor to me to use journaling. It may be a word. You may be just totally angry about something. You just want to write it down. But writing and journaling to me is very important. I became better at it, after Angela's death. My wife died of glioblastoma less than 2 years ago. And probably the best counseling advice I got was to journal. Begin to journal how you feel. Begin to journal through grief. It's a very effective way to sort of check in with yourself. And you'll be amazed at once you get good at it, you'll fill up 2 pages without a blank. Just put it all on paper. And it's a very good way to check in with yourself and say, okay, where am I right now? So both are good. Reflection, sanctuary, journaling, they're all very healthy.
Tim, we're so sorry to hear about everything that you've gone through, especially with Angela. I know it's not easy to talk about. I want to just ask about the topic of journaling in a more practical way. Like, how does someone start doing this? Is this something that you set time aside for? Do you do it in the morning? What does it look like on a practical basis? Do you write notes on your iPhone, or do you put electronics away?
So I'm old school. I have a journal that I write in. Like most surgeons, I'm most alert in thinking in the morning. So most of the time I will journal in the morning, sometime before my workday starts. And sometimes I'll dog-ear the page and come back later because I want to write more. I just don't have time at that moment. But I'm more alert, kind of check in with myself in the morning early versus the evening. But again, in the evening, I might see some during the day that I want to write down right away. So it's sort of like something comes to you and you got to wake up and make a note because you're afraid you'll forget it. Journaling can be sort of like that.
Thank you, Tim, for sharing that. I'm going to go back to the leadership discussion. And we know a big part of leadership is recruitment and retention. And I've always heard you say we need to invest in the right people. And especially now, I've heard it during our residency interviews, faculty recruitments, and you mentioned Dr. Gene Caltern kind of showing you how to build a department, bring on people. This code has stayed with me now that I have a big team myself, a research lab and residents. Can you share with us a little bit more about that?
I think it's everything. If you're running a department and you're truly a servant leader, then hiring and investing in the right people, letting people fail, it's hard, I can tell you. But they do. They're human. It's just how much failure is tolerable. I've certainly seen my fair share. I think character is critical, which is a hard thing to read, the character of somebody, their integrity. And so those are really important. But I think once you commit to somebody, you owe it to them to give them your time and attention and check in and be sure they're doing okay. What do they need? What are their frustrations? I always had an open door policy. If you wanted to talk to me and I'm here, you just walked in my door. You didn't have to make an appointment. You didn't have to do anything. I kept my door pretty much open and available. And that was important to me. That's the way I wanted to be treated by my boss or superior or my chair. And so I offered the same to faculty and felt like they had an open door to come to me. I tried to treat staff the same way. And some were intimidated and just didn't want to do that. But I had plenty of medical assistants who would come in and say, "Do you have a minute?" "Sure, come in, sit down." I think that's important. So I think hiring is difficult. Retention's harder than hiring.
So, Tim, what I truly remember when you were chair wasn't just having an open door policy. You actually did come in to our offices and our rooms pretty frequently and ask, "Is there anything I can do for you? Do you need anything?" Like check in at the end of the, a month or day. Just check in with us. I really appreciated that check-in and that open conversation that you asked us if there was anything that you could do. Just hearing us out, it was really impactful. You shared the memory of Angela, and she was very dear to all of us, and her passing, we're all very saddened about it. But in regards to leadership, I want to ask you, if you feel comfortable sharing, is there any memory that you can think of that you wish you had handled it differently during your leadership?
Sure. Leadership is demanding of time. I think if there's one regret, it's just balancing my time better. So I'm really careful to tell the medical students, balance your time. Don't forget about your family and your other leadership responsibilities. As a husband, as a father, carve out that time. It's not the amount of time, it's the quality of time. In retrospect, I think I learned that I didn't do that very well. And certainly, losing Angela really reminded me of that. And had we had more time, I'm sure many of our conversations would have centered around that. Not like you could redo it, but just talking about it was healthy for me, for sure, would be, important. And I certainly hired my share of lemons. And like I tell people, it's a lot easier to get married than it is divorce. That's somewhat painful, can be expensive. So when you're hiring, especially people who are really critical to your faculty, due diligence, you can't do enough of it. You really got to work the network. You got to check with people, always by phone. Nobody wants to write anything down, and I understand that. I've been on the other side. But you really can't do enough due diligence to be sure that this is the right fit, the right chemistry. All it takes is one person to blow up your department, your culture, and everything. So you really have to guard that carefully. And a lot of it is just working with people that you trust and say, "Listen, I really need to know about this person." So you take your best shot at hiring.
One of the striking things that Rose talked about your ability to be available and really checking in, I think that was pervasive through the whole list of trainees. Every level of resident would get the same question. You were genuinely interested in how they were doing and what they needed support with. And I think that was an incredible culture that was consistent, not just for faculty. I wanted to kind of get your sense on how it was transitioning from one particular culture, so to speak, at one health system to another. What were those challenges like from a culture perspective? But of course, there's the, infrastructure may be also different. But could you speak to the differences in those perspectives?
Yeah, it was markedly different. Again, I was a very young chair. I think the first big difference is the majority of my faculty were older than me. And following Peter Scardino wasn't an easy, it was quite a challenge. I felt like I had to have their support. And the first conversation I had with the faculty was, "Look, guys, I'm glad to glue us together, but I need your help. I mean, many of you I lean to, many of you have been mentors, many of you have done this and that. And again, I need your help to do this." The other thing that was different, one, it was a medical school, which has a completely different infrastructure. But as a chair, you had a lot of autonomy. You had your own research space. You had your own education. You ran it from top to bottom. So your autonomy over your department was quite large. When I came to Methodist, it was very different. They had a centralized research. You had to basically negotiate for everything, from startup package to space to everything. Some people resented that, but now that I'm more involved in administration, it's much more cost effective and fair. So if you have the grant support and everything, your space is commensurate with what are you towing your part of the weight of an institution, where just depreciation is huge on a building. So I understand the budgetary side much better than I did at Baylor, just largely because the autonomy was different. That was a big deal. I think I resented it at the start, and I fully understand it now when I kind of see how things run. The other is Methodist was always my home clinically. So I didn't really have to move health systems because most of what I was doing was already here. They already knew me. I knew them. I knew a handshake was as good as gold with the people I was dealing with, which is very important, this trust of each other. That was important. I think the fact that they trusted me to start a new department from scratch was very trustworthy on their part to kind of instill that confidence in me. But I have to say that really the thing that made it work the most were a lot of my mentors in the older chairs with a lot of wisdom came to Methodist when the separation occurred. So they didn't leave me. I just could always continue to tap them and see how they were coping. Some of them pushed back pretty hard against the administration here because they didn't quite understand what an academic department's about. They were only doing clinical work. They had to sort of learn and they're still learning, honestly, what is an academic medical center all about beyond just clinical care. So I've been a part of that process since day one, which is, again, can be frustrating to get a point across when they're mainly interested in the clinical volume and margin and all those things, which are important, but that's not all it is if you really want to be a credible academic health center.
Tim, you've taken your career through various stages and, really having an impact on education and administration at the highest levels. And that could be a full career for many, many people. Yet, the evolution now is a very, very different role that you carry as a vice dean of our medical school, which is a completely different hat that you wear. For the audience who probably doesn't know the concept here, it's an engineering medicine program. And, I'd love to hear your perspective on why this, program was needed, why you felt that you had to kind of play a role now in shepherding this through and how that came to be.
Well, honestly, as I self-reflected, I was burning out. I felt like I wasn't giving enough to either side. I had no business continuing to try to chair a department when I was being pulled away, and actually purposefully on my part to fulfill this need to avoid burnout. So that's the selfish part that really came from journaling and reflection. I needed to make a change and commit the final part of my career to something I love to do, which was education. So that worked for me. I just had to be sure that it wasn't to the detriment of this department that I loved so much. And so the timing of stepping down was critical. I probably should have done it a little earlier, but that worked out great because KK is a wonderful chair. I haven't talked about my dad a lot, but he was a huge influence. And there's a quick story to my dad. When he joined the Army right after World War II, he was to go to his camp, to boot camp, and he got on a train and realized he'd gotten on the wrong train, that the Army's papers were wrong, because my dad was an engineering major. And he was sent to medical tech school. And he went up to a lieutenant and he said, "Look, I think they made a mistake." And he said, "Sit down, boy, the Army doesn't make mistakes." And he ended up at med tech school, and that's why he went to medical school. That's why he was a doctor. But my dad was fundamentally an engineering in thought. He bought a pipe organ from Iowa, had it shipped to our house, and installed the thing in our attic. It was totally crazy. He loved to build water sculptures out of bronze in the backyard. He created a laser light show for my little brother's band. So he was fundamentally an engineer. That's one thing that really captivated my interest when the three of us, the Dean of Engineering, College of Medicine, and Houston Methodist sat down and talked about what if, essentially on the back of a napkin, to graduating our second class this year. So really watching the program. I love program development, but I also like picking good people and getting out of the way, letting them really succeed so I can move on to another project. That's sort of self-fulfilling, but that's what I love, to fly around good people and let it go and move to something else. You could call it attention deficit disorder. I'm not really sure, but that's what I've always loved to do. But I attribute the engineering interest out of my dad and realizing that he was a great combo. That's why he embraced technology. And I thought, boy, what if you had 50 kids doing that every year? What could they do? Just watching him tinker around and fix stuff, I thought this would be just wonderful to watch. And it really has been. These medical students blow me away every day.
It's been truly a pleasure having them in our clinics, these bright, innovative, eager to learn, eager to solve. I think this past year was the first time that they were going around the country and interviewing for urology. So I got quite a few phone calls from program directors asking, what is this NMed program you guys have? And I was like, these are like one of the brightest students going to be doing really innovative things in our field. So I think it's going to make a huge impact in medicine overall. So Tim, you mentioned burnout, and you mentioned how when you noticed it, you acknowledged it, you had a plan to transition or pivot. For us, I feel like the healthcare administration, the expectations, the responsibilities are just getting more and more RVUs, more grants, more publications. It doesn't matter if you're just clinician 100% or research scientist. There's going to be things that are going to be pulling us in all directions. Any thoughts or suggestions on how we can make sure that we're staying grounded, we're practicing empathy?
I think, again, it comes from reflection. It comes from building a broad mentoring base with different attributes. Some are really budgetary. How do you kind of manage all that's going on? You remember, Rose, I told you early on that if you're going to run a lab, you better understand all the intricacies of budget. You're always writing grants. You're always doing that to keep your budget in order, or suddenly the thing will collapse on you. And basically, I learned that lesson the hard way by not paying attention. I think time management, again, both of you are perfect examples of managing your time, because you can get all consumed by this RVU hassle. The beauty of academic urology is you can shift gears. And my administrative assistant, James, knew that when I was in the lab, unless somebody was bleeding to death, don't bother me. This is my time to be in the lab and to focus exclusively with the PhD in the lab. He deserves my time, and that's where I want to be. That's, again, my sanctuary in many ways. I think it's time management and not letting the other consume you, because it will be pretty soon. You'll just be so distracted by the noise, which will always be there. They're always going to want more RVUs out of you. But it's okay to say no and to push back, and then use your leverage, which both of you have a lot of because you're so well respected here. Use it to your advantage and say, can I meet with you? And just, say, look, this isn't fair. This is not working out. It's not why I'm here. And just explain yourself. That's worked for me pretty well. And only cash in chips when you have to, but always collect them. Collect those chips, because I guarantee you're going to have to cash one in or two here and there. And it's easier to do if you have a nice collection of chips.
Tim, I got to say that this has been an amazing experience for both of us to really hear from your perspective on how much you've given for education and administration, and, what you continue to give. I think, you're a true legend in urology, and, we've really benefited from having you, touch our lives and see how you've touched so many others' lives and continue to do so, especially the medical students in the engineering medicine program. I think, the key takeaways in thinking about a lot of the messages here in this particular discussion, really about empathy as, the foundation of kind of how we connect with our patients and how we are aware and being present is so critical. And, I love the fact that you really brought into the whole discussion of leadership, that self-reflection should be a critical part of it. We really need to turn the lens on to ourselves. I would really enjoyed this, and I'm sure Rose as well, and I'd love to hear any further parting thoughts from you.
I would say, never forget that it's a sacred opportunity and privilege to take care of people. They're bearing their soul. They're telling stuff to you they don't tell anybody else, including their closest partner, whatever. Well, that's a privilege. So enjoy every moment. I guarantee you they'll teach you more about yourself than you'll do for them if you really open up and listen to them, listen to their stories, because you're storytelling. Basically, you're listening to their story, and if you put empathy in there, your ability to be their doctor, to make them compliant with what's in their best interest, is so much easier than trying to talk them into something. If they trust you, they'll just do it because they feel like you're really interested in them. But have fun. Don't make the job a drudgery, If you're around a bunch of people and you got a great culture, enjoy each other. That's the beauty of kind of stepping aside and watch KK kind of re-energize the socialization and the culture and, having a good time, laughing together, going out together, sharing family with each other, family stories. That, when you're talking about retention, that's what retains faculty. It's not more money. It's not another contract. It's the fact that if I left this environment, what would happen? Is the grass really greener over there? It probably isn't. If you're in the right culture, in the right setting, and you're happy and you like your colleagues, that's how I would part. But enjoy it. Don't make it a job. Make it a privilege and a calling.
Thank you so much, Tim. This has been really a joy. And for me personally, just watching you in clinic during my residency, afterwards as my faculty and my mentor, and hearing your lectures. And I've heard different versions of these discussions. And every time I keep learning more and more and more. So it's been truly a privilege. Thank you for being with us today.
Thank you. Thank you both.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.